Okay. Well, I want to make sure that we get started so that Dr. Dichter is able to have a full use of this time. So my name is Amy Lynch. I'm an associate professor of occupational therapy in the College of Public Health. And it is my great pleasure to be representing a large group of interprofessional faculty members university-wide here at Temple University who are sponsored by the College of Public Health with the goal of being a trauma work group with an initiative to spread awareness of trauma and offer trainings and opportunities for community members at large to be able to understand different aspects of trauma and considerations for how it might apply to them as individuals, systems, organizations, professionals, personally. And it is with great thanks to Dr. David Sarwar for sponsoring our group and for giving us this space for these collegial gatherings. Today, it's my great pleasure to introduce to you Dr. Melissa Dichter, who is an associate professor in the School of Social Work at Temple University, as well as a core investigator at the Center for Health Equity Research and Promotion at the U.S. Department of Veterans Affairs, and a fellow of the Robert Wood Johnson Foundation Interdisciplinary Research Leaderships Program. Melissa has over 15 years of experience conducting research and scholarship related to intimate partner violence and trauma-sensitive responses. Her work focuses on understanding the needs and perspectives of individuals who have experienced intimate partner violence in order to inform improvements to societal responses. Melissa takes a trauma-informed and a community-engaged approach to her work, centering the expertise of lived experiences into her research. We are grateful to have you here today, Dr. Dichter. Thank you so much for joining us and being willing to share your time and expertise.
Thank you, Amy, and thank you everyone for being here. I hope you will engage with us through the Q&A function. I don't think that the chat function is open to participants, but please put in questions and comments in the Q&A, and Amy will moderate those, and we'll have time at the end for discussion. So today I am going to be talking about addressing intimate partner violence in the healthcare setting. We can also talk about how this work applies to other settings as well. I'll be sharing with you some findings from research that colleagues and I have conducted related to this work, some case examples, and the expert words and voices that I'll bring in are based on the expertise of the lived experience that we've received through participants in qualitative interviews. So I want to recognize, as we all know, that we're now a year into this COVID-19 pandemic, and that the COVID pandemic really exacerbates the existing domestic violence or intimate partner violence pandemic and really makes addressing IPV in the healthcare setting even more important. I also want to introduce you to Maya. Maya is a pseudonym for a real person who is a 32-year-old African-American woman. Maya presents to the emergency department with a vaginal infection. In the emergency department, she receives an IPV screen as part of emergency department triage process, and her abuse screen is negative. So why are we talking about Maya in this talk about intimate partner violence? Well, we're going to come back to her situation towards the end of the presentation today. I want to give a little bit of background on IPV for those who are less familiar with the topic. IPV refers to intimate partner violence, also sometimes referred to as domestic violence, and really refers to this sort of umbrella term that is about experience of violence or abuse from a current or former intimate partner. We often think about physical forms of violence like hitting, but it's important to recognize the variety of other forms of violence that constitute intimate partner violence. So these may be sexual forms of violence, can include stalking or harassment, verbal, psychological, or other non-physical forms of violence. Also social, economic restrictions and limitations. IPV often includes coercive control, often causes fear in the recipient, and can lead to psychological trauma experience. In terms of statistics, we have some statistics here about prevalence in the United States from the Centers for Disease Control and Prevention. But I think it's important to take note that the statistics really vary depending on how and what we're measuring, what questions we're asking, what forms of violence we're talking about, who we're asking, and how we're asking it. The key points that I want you to take away is that IPV is prevalent in the US and worldwide, that the impact of different types and forms of violence really vary depending on a variety of contextual factors, but that no one is immune from experience of intimate partner violence. IPV affects all segments of society. And although the work to date has really focused on this male-female gender binary, we do need to move beyond the binary conceptualizations of gender in this work and in all of the work that we do. IPV can have a variety of impacts on physical and mental health, acute chronic health conditions, as well as on social conditions related to, for example, housing stability, criminal legal system involvement, unemployment, can impact a variety of segments of society. And I have this ripple image here to sort of reflect this rippling impact of IPV. We know that IPV affects people's children and other friends and family members, coworkers, employers, larger societal systems. So we think of sort of the rippling or radiating impacts of IPV. And what is the question most asked about people experiencing IPV? It's a question that you may have asked is, why don't they just leave? Why do they stay in this situation? Well, the answer is that people do leave relationships in which there is violence. Leaving is a process. It often takes a lot of time. It may not be permanent, certainly not easy. It may also not be safe. So the point at which someone decides to leave or take steps to leave an abusive partner is the highest risk for escalation of violence, and is often when violence turns fatal. There are, of course, a lot of losses associated with leaving, losses of relationships, sometimes of home, of finances, of other relationships in one's community. And people often face barriers to leaving due to concerns of well-being of others, for example, one's children or pets. We can also consider alternatives to leaving, that perhaps there are possibilities of achieving nonviolence within a particular relationship. So leaving is not always the answer and is not always feasible or safe. In fact, here are just some of the barriers that people may face to leaving a partner who is engaging in violence or abuse. So there are lack of resources. Where might someone go? Not having anywhere to go, not knowing where to go, where to turn to for help, having financial dependence, love for partner and fears of being alone, legal concerns, citizenship status, other kinds of dependence, threats and fears of further violence, etc. So getting now to talking about addressing IPV in the healthcare setting. Why should healthcare providers or clinicians address IPV? Well, one factor is that we know that IPV is relevant to health and healthcare access. As we've seen, some of the impacts of IPV are related to impacts on health as well as access to healthcare. An intimate partner may restrict access to healthcare, for example. So IPV is a health issue. It's relevant to health and it's relevant to healthcare. Addressing IPV in the healthcare setting is also an opportunity to provide intervention and support. In fact, this may be the first opportunity that someone who's experiencing IPV has to share that experience with someone else in a safe and secure environment, to learn about help and resources, to get some validation and support. We also know from years of research now that both patients and healthcare clinicians endorse the idea of routine screening for IPV in the healthcare setting. But I want to be clear here that screening is not the end point. Screening is really the starting point. The purpose of screening is not just to identify who's experiencing IPV, but really to help facilitate disclosure of that IPV experience so that someone can get support and resources that ultimately impact their well-being. The healthcare setting may be even more important during this COVID-19 pandemic, where people are limiting their access to other people in other settings. The healthcare setting may be the one place that people are going outside of their homes, especially during this pandemic. U.S. Preventive Services Task Force updated their IPV screening guidelines in 2018, and they recommended that clinicians screen for IPV in women of reproductive age and provide or refer women who screen positive to ongoing support services. So the important pieces to remember and to think about here is that there is a recommendation for routine screening for all women in this reproductive age group, which generally refers to women younger than 45 years old. And that the screening, again, is not the endpoint, but then to provide or refer to further services. But I also want to be clear here that the U.S. Preventive Services Task Force guidelines are based on a review of available evidence, generally from randomized controlled trials. And the majority of the randomized controlled trials in this area have been conducted among women of reproductive age. So that's where we have the evidence. They concluded that we just don't have the evidence at this stage from the randomized controlled trials to support recommendation for routine screening of other populations. But we'll talk about some newer evidence that we've gathered since this statement. So we're talking today about trauma-informed approaches, and I want to be clear about what we mean by trauma-informed. So the Substance Abuse and Mental Health Services Administration, SAMHSA, has put forth recommendations and guidelines for trauma-informed care and trauma-informed services and organizations. One of the components that SAMHSA talks about is what they call the 4 R's, and that's what these 4 boxes are here. And the first R is about realizing the widespread scope and impacts of trauma. So this is really about being informed, doing the kinds of things that we're doing here today, is taking note of the prevalence and the impacts of trauma experiences like intimate partner violence. Second is recognizing the signs and symptoms. So I think of this one as sort of pay attention, right? Think about when you're interacting with someone, might there be trauma effects going on here that are impacting someone's behavior or experience or my perception of what's going on? Third is respond. Respond by integrating the knowledge that we have about trauma into our policies, our procedures, and our practices. So the takeaway here is like, be helpful, right? Think about what we're doing in a trauma-informed way. Think about how our behaviors may impact someone's experience in that context of trauma. And the fourth one I've put in a larger box here because I think this is really the key point, that we want to resist re-traumatization. What we want to do here is prioritize physical and psychological safety, trust, and empowerment. These are the kinds of things that IPV has eroded. IPV erodes a sense of physical and psychological safety. It threatens one's sense of safety. It threatens one's experience of trust and of power and empowerment. So those are the things that we want to be sure that we're not further perpetuating in our responses. So I want to share with you now some of the research findings that we have come across in looking at clinical screening in the healthcare setting for IPV. Who's screening positive? What are the demographic and clinical characteristics associated with positive IPV screens? You may know there are a variety of screening tools that are recommended for use in healthcare settings and are validated. This is one of those tools. It's called the EHITS screening tool. EHIT stands for Extended Hurt, Insult, Threaten, and Scream tool. The original tool was the 4-item HITS tool, and the extended piece adds this 5th item about forced sexual activities. So the first item is measuring physical intimate partner violence. In the past 12 months, has a current or former intimate partner physically hurt you? Second, third, fourth, insulted you, threatened you with harm, screamed or cursed at you. These refer to non-physical forms of psychological or verbal violence or abuse. And again, the 5th item related to sexual intimate partner violence. The response options range for each of these from never to frequently. scored as a 1 to 5. And what we found in research on this tool is that a score of 7 or higher is generally considered positive for past year IPV. But it's important to recognize that this is not a diagnostic screening tool. We are not diagnosing someone with intimate partner violence. We are using this as a tool to help identify who might be experiencing intimate partner violence. This kind of tool is often used as part of routine screening or routine inquiry of women patients in a primary care or a women's health setting, but it can be used in other settings as well. What I'm going to present to you is some findings that we have from the Veterans Health Administration, which is the nation's largest integrated healthcare system. It covers the entire nation of the United States and serves military service members, veterans, and some dependents of military service members and veterans. I want to look here at comparisons of survey research versus clinical screening data. In survey research of women veterans who had received VHA's Veterans Health Administration care in the year prior to the survey, asking about past year IPV, we see 18.5% of respondents to that survey screened positive for past year IPV on one of these validated screening tools. And we see that when we break it down by age of the respondent, there's the highest rate is among those age 18 to 30 years, and the percentages go down with the age groups. When we look at clinical screening data, so these are data that we pulled from VA medical records where screening had been implemented, routine screening for all women patients. Here, this was without an upper age limit. So although the US Preventive Services Task Force recommends routine screening for women of reproductive age, in this setting, there was no upper age limit. And here we see much lower portion screening positive for past year IPV. It's 8.4% overall versus the 18.5% we see in survey research. But we see the similar trend with the age groups of the proportions decreasing by age group. What I want to highlight here is the first two bars in both of these charts represent those women of reproductive age. And we do see higher proportions here. But we also still see substantial proportions of past year IPV among women older than reproductive age. And so the take-home points that I want you to take from this slide is that clinical screening does not equal prevalence. We see lower rates of positive screens in the clinical setting than we do in survey research. That actually doesn't surprise me, given what I know and what I will share with you about barriers that people face to disclosing IPV experience in the clinical setting. It's also important to note here that IPV does not end after reproductive age. So when we don't put an upper age limit on our screening, we still see people in these older age groups who are reporting that they are experiencing past year IPV and thus may benefit from some intervention or support. When we look more deeply at the forms of past year IPV, this is among those 774 patients, that 8.4% who screened positive in the clinical setting in VHA, we see that 99.5% report psychological forms of violence. And only 23.5% of those who screened positive are reporting physical forms of violence. So the takeaway here is that if we're only looking at physical forms of violence, we're really missing a big piece of this picture. And that's really important because so many people think of IPV as only physical. And if we ask, for example, has anyone hit you or physically hurt you, we're going to miss this big group of people who are reporting psychological forms of violence and not other forms of violence. And we know from research that psychological forms of IPV, even in the absence of physical or sexual forms of IPV, can have great adverse impacts on people's health and well-being and experiences of trauma. Also from these same data from clinical screening, when we look within 6 months following the positive IPV screen, again from medical records data, we see that those who screen positive for IPV versus those who screen negative for past year IPV have higher proportions of all of these mental health diagnoses, any mental health diagnosis, 2 or more mental health diagnoses, anxiety, not including PTSD, depression, alcohol abuse, drug abuse, and post-traumatic stress disorder. And what I want to highlight here is among this group screening IPV positive, more than 50%, more than half, have a mental health diagnosis in their medical records within the 6 months following IPV screening. I want to be clear here that IPV is not a mental health diagnosis, but it does impact mental health. We also see that screening positive for IPV is associated in the 6 months following IPV screening with increased rates of housing instability. Almost 1 in 4 of those who had screened positive for past year intimate partner violence on routine screening for housing instability also indicated that housing instability was a concern for them. 6.6% had indication of suicidal ideation in their medical records, and more than a quarter had an emergency department visit in the VA healthcare system within 6 months following that IPV screen. So we want to think about the intersection of these conditions and services. If we're talking to someone about housing instability, for example, we might want to probe and ask about experiences of intimate partner violence. And when we're talking about intimate partner violence, we need to also consider housing needs. Same for other conditions. When we're coming across suicidal ideation, we should be thinking about, is intimate partner violence a piece of this picture? And is that something that we need to address? So I want to move into talking about what patients tell us and what survivors of intimate partner violence tell us about IPV screening and response. And these are really the expert voices that people have shared with us in qualitative interviews. So I have several quotes from those interviews that I will share with you to illuminate some of these key pieces. One important piece is to simply ask. Asking facilitates disclosure, and that spontaneous disclosure is rare. So this participant shared with us that no one ever asked me about it. She said, I was walking around with a black eye and not a single question. So I may have talked about it if I had been given the chance, but I wasn't going to bring it up on my own. Here we know that it's really important to ask people when we have suspicion or if it's part of routine screening, that we should be raising it with people, providing the opportunity for people to disclose and seek help for their experiences. And it's important to not just ask once and leave it at that, because people may not be ready to disclose the first or even the second time that they're asked about it. That comfort in that clinical relationship really matters. And this is illustrated by this quote of a participant who said, in response to being asked about experience of IPV, she said, I said no, because I didn't feel like talking about it. At that time, I wasn't ready to talk about it or get into it with anybody. There are a lot of things I didn't tell my doctor when I first started seeing her. But once you get to know a person and you know the doctor, you can start opening up and saying stuff. And it's important to remember that IPV can be a traumatizing experience. People can feel a lot of shame and stigma and fear and concern. So it's not something that people can necessarily easily disclose, especially if it's their first encounter with someone. It doesn't mean that we shouldn't ask, but it does mean that we should realize that even if someone says no, it doesn't mean that they're not experiencing IPV. And when we ask, we really need to ask in a way that is trauma informed. So here are a couple examples that are not trauma informed. One participant said, I don't think I'd be comfortable talking to my primary care provider. She did ask once. I felt like she was judging. I did not feel safe. Another participant shared, I had a partner who went to my appointments with me, and when I tried to ask for help, I couldn't because that person, referring to her partner, was right there. I would say, she could stay out here in the waiting room, and the provider would be like, no, she can come in, and I can't ask for help because of it. So it's really important to pay attention to those cues. It's really important that we provide the physical and psychological safety to allow someone that opportunity to disclose and get help. And even if a patient doesn't disclose, just simply asking shows that you care. This participant is referring to seeing an IPV screening question on a paper form. She says, if you're not ready to tell, but you see that question, you know that they care and they're interested and they may be able to help. It's like a signal that this is something that we care about here. It is important to have those signals, whether it's through screening and asking about it, having posters or signs or other materials to let people know that I am aware that people are impacted by intimate partner violence. I am someone you can talk to about this. This is a place where you may be able to get some help and support. Another participant, and this is reflective of several people I've heard share a similar experience, who say, the whole time when I was in a clinical encounter, her head, the clinician, was down or typing or writing. And it was like, why are you asking me these questions? It's not like you even care as to what the answer is. You're just doing it because this is something you have to do. You have to ask these questions. And we see that when, sometimes when we implement routine screening, we simply add that screening question onto a long list of other questions that people are required to ask. So you may have that experience where someone is typing into the medical record or writing into the chart and just kind of going through the list of questions. And that can make people feel like you don't really want to know, or you don't really care. You're just simply asking the question because you're required to ask the question. And that can really inhibit disclosure. And it's really important to remember that disclosure is really an opportunity to help. And so when we don't provide help in response to disclosure, it's a missed opportunity. This person says, if it wasn't for my doctor, well, the kid's doctor telling me about this domestic violence program, I wouldn't have known about it. I went to the emergency room a couple of times for domestic violence and I reported it. I was looking at my paperwork recently, this is from the emergency department, and it said alleged partner abuse, and they didn't do nothing. They just treated me for my injuries. So this is someone who had gone to the emergency department for an assault related to domestic violence, reported that this was domestic violence. It was documented that it was domestic violence, and no one offered her help for that. She didn't know that there were programs in the community and services that could help her until later when she went to a pediatrician visit for her children, and the pediatrician had referred her to a program. So talking more about barriers to disclosure and why people might not disclose even when asked, and this can inform how we do our asking. So we know that there are a lot of barriers to disclosure. These include shame or embarrassment about victimization, denial about experiences, or feeling like maybe it's not that bad or it's not a problem, real fears and concerns about retaliation or increased violence, concerns about how clinicians or providers might react and respond, concerns that it's maybe not relevant to their healthcare and the healthcare setting, or not feeling ready to share or talk about it. This participant said, it's not something you run around and tell people. It's a private matter. It's an embarrassing situation. People have a way of condemning you or belittling you or looking down on you in ways that you may not even realize that they do. So you just don't talk about it because you don't want to deal with all that. And I think as part of our trauma-informed approach, we need to really think about and remember and recognize the shame and the stigma that people can feel and perceive related to experience of intimate partner violence, and be thoughtful about that in the way that we ask and the way that we respond to disclosures to make someone feel comfortable and more secure with sharing that information. People also have concerns about the consequences of what will happen if they do disclose. This participant said, when my daughter's doctors ask me about IPV, I think they're going to do something like take her away from me. Now, when my regular adult doctor asks me about IPV, I think they're going to call the cops on him or something like that. People often don't disclose because they don't know what will happen when they do. And it's important then to clarify why you're asking and the ways in which you can help, and let people know what the risks are and what will happen. Are you going to call the police? Are you going to take the children away, for example? This participant suggested, I think they should give you an option to confirm, yes, it occurred, and no, I don't want to talk about it in the moment. Because if I don't want to talk about it, I'm more than likely to just say no. So on that clinical screening, someone might receive that question and maybe they are experiencing intimate partner violence, but they don't necessarily want you to intervene at that moment or even push them and force any kind of intervention or conversation. So instead of saying yes, they say no. And that's one of the reasons, right, why our clinical screening data look really different than our survey data, where people can feel safer to report and not feel like that's going to lead to some kind of intervention they might not want. In terms of providing services and support, one way that we can provide support is by just having an empathetic, understanding response. But another piece is really helping connect people with services and programs and interventions, whether it's for housing support or domestic violence shelters or counseling or safety planning or legal assistance. There are a variety of services that people often don't know about and don't know how to connect with. And so that the healthcare setting may be a way that they can do that. But people have told us over and over again that just giving them a hotline number or a resource sheet isn't enough, especially in a context where you're feeling trauma and you're feeling overwhelmed and you're feeling shame and stigma and fear. People want more than just a number. This person reflected on an experience where the hospital that she was at had a relationship where they actually connected her directly with an IPV program. She says, they didn't give me papers or information and tell me to call this place. They asked me, can we give them your information and let them contact you? She says, if I had to contact them, I probably never would have did it. If the hospital would have just gave me a number and pamphlets, I would have took it and stuck it in my bag. And then maybe one day with a busted head and a black eye, I think about, man, I should have called this place. Too late then, but because they reached out to me first, I got involved in the program, whereas I wouldn't have just called. So this participant felt like it was really helpful to have that outreach from the program, but it's really critical also to note that the hospital staff first asked the patient in this case if it was okay for the program to reach out, and it is critical that you get that consent and approval. Another participant reflected her experience. She said, where do I go? Where am I going? What do I need to do? I was having so much of an emotional breakdown that emotionally and mentally I was screaming out for help, hold my hand through a situation. Even if, like I said, you sit down and someone makes a call with you, okay, that's supporting. That's like giving you a hug subliminally. Again, people are reflecting on this crisis moment, this experience of trauma. They want more help. They want someone to help navigate, even sitting down and making the call with them or offering to do so can feel more supportive than just giving someone a referral number. We talked about trust in the beginning in those 4 R's of a trauma-informed approach. And this one participant really spoke about that trust and why trust is so important in the context of trauma related to intimate partner violence. She says, that person that we love, our significant other, has already broken our trust, right? When you experience violence or abuse from someone with whom you're in a relationship or you have been in a relationship, that can feel like a real betrayal of that trust. And then she reflects on the helper, the clinician, and she says, if you prove to me that you're not trustworthy, I'm going to go back inside. I'm going to go retreat from help seeking. She says, so say I'm even trying to escape a situation or try to whatever, and you're telling me that I can reach out to you, and I do, and you're not there. Oh, come on, you're hurting this person even more. So we really need to think about trust and being available when we say we're going to be available, talking with people about the contingency plans. How can you reach me? When can you reach me? What if you can't reach me? How else can you get help and support? Who else is going to be here to help you if I'm not? And we want to think about trauma in multi levels and multi-layers, and systemic trauma and intergenerational trauma and historical trauma as well when we're thinking about that fourth R of resisting re-traumatization. This is a quote from someone who felt like she had a really negative experience in a hospital setting related to intervention and response to her disclosure of intimate partner violence. And what she says of this clinician is what she did would make someone not want to go back to that hospital the way she did it. When you bulldoze people like that, people are less likely to get help. Then she says, and especially people of color are already scared to get help. And we know the system isn't necessarily fair in general. So it makes it harder for people to feel comfortable doing so. So we have to remember the context of people's lives and the various ways in which trauma can come into play. For example, some of the police brutality and racism and anti-Black racism and the anti-Asian racism and violence that we've been seeing, these can all factor into someone's experiences and be part of that trauma response. And we need to really consider that in the way that we interact and talk with people and offer help and support. Thinking about documentation, many clinicians have been trained to document everything and document in detail. And documentation of experience of intimate partner violence can be really helpful. It can be helpful in later court proceedings. It can be helpful for continuity of care. But people feel also a lot of concerns about the risks of documentation, concerns about privacy, confidentiality, and safety. And these can lead to decisions to not disclose and to not seek help because of concerns, particularly related to documentation. We have a quote here from someone who says, one of these young interns, he brought up the discussion of something that I had discussed with my psychiatrist in privacy. Then I come to find out any staff member that has a computer can put in my last 4 digits of my social security number, can read my record. What privacy is that? So after that, I was very skeptical. I ain't talking to you if you're typing it up into the machine. So here's a real illustration of a missed opportunity to provide help and support for someone who feels like she's not going to share with her clinician her experiences because of the concerns related to documentation and other people seeing that. What we recommend then is that there be transparency, patient engagement, and conversation, shared decision-making in those decisions around documentation. That there's a discussion about the rationale for and concerns about documentation for each individual case. And I'll show some examples of this when I get into some case examples. So these case examples are based on real cases of patients whose experiences has been documented in their medical records. In this case, these are again of medical records from the Veterans Health Administration. And I'm going to present to you examples from 2 cases. One details over a 4-year period, and then one much briefer. But the 4-year period, this is going back to the case of Maya, who we met in the beginning of this presentation. In the first year that we looked at, in the month of October, Maya presents to the emergency department with a vaginal infection, and her abuse screening is negative. That's what I shared with you in the beginning. That same month, she has a behavioral health intake with documentation of a bad relationship, but that she doesn't want to discuss it. In May of the following year, she has another emergency department visit, this time for lacerations. Patient reported from a fall. There's again abuse screening conducted, and her abuse screen is negative. The following month, there's documentation of an unintended pregnancy that results in miscarriage. And a month later, there's a call to the crisis hotline that's associated with the hospital. And there's documentation of an IPV-related police incident. There's ongoing abuse. She has a restraining order and her boyfriend's in jail. The following month, another emergency department visit, another vaginal infection, another negative abuse screen. But also that month, she has a primary care visit where she's given the EHIT screening, and she responds to each of those 5 items with the highest score of frequently. That day, she has a same-day consult with the hospital-embedded IPV coordinator. And these are notes from the coordinator, IPV coordinator's documentation. What I want to highlight here is that there's documentation that this person has been in an abusive relationship with her ex-boyfriend for 10 years. Physical abuse, latest incident 30 days ago from a physical assault. The IPV coordinator provided emotional support and validation, discussed stress management, reviewed resources, and offered follow-up. So then in November, a couple of months later, there's another ED visit, this time abdominal pain noted, and again, a negative abuse screen, and followed up by a primary care visit where the patient reports pain, she says, due to a car accident. There's no documentation at that visit regarding intimate partner violence. In March of the following year, another ED visit, this time a burn, and again, a negative abuse screen. In the following month, she has a documentation of another unintended pregnancy resulting in termination. A few months later, another ED visit, this time documented that this is from an assault from an ex-boyfriend, positive abuse screen, and she's referred to the emergency department social worker. And the month after that, another ED visit for another vaginal infection, another negative abuse screen. That same day, she has a mental health follow-up visit with documentation of IPV. The next day, she has a 5-minute telephone call with the hospital-embedded IPV coordinator, plans for an in-person appointment. That happens about a week later. There's a 1-hour in-person visit with the IPV coordinator, and the documentation states, at veteran's request, detailed information is not documented in the medical record. A couple of months later, she has an ED visit, this time for sinusitis, and the abuse screen is negative. And a month later, another mental health visit where there's discussion of IPV, notes that she has left the relationship, she's pursuing a restraining order. She has a social work consult regarding IPV and a telephone call with the IPV coordinator. They have an assessment and make a plan. And in May of this 4th year, she has another ED visit, this time with vaginal odor. It turns out to be a positive pregnancy test. It's documented that this is in a new relationship. And here her abuse screening is negative. So the key takeaways I want to share with you here from this example, because I think this brings up a lot of important and illustrates a lot of important points here. Over this 4-year period, there were multiple healthcare visits. In fact, there were a few others that I didn't even document here for you. Primary care, behavioral health, and emergency department. Each of these is an opportunity for intervention to provide support and connection to resources. Also, we see over this 4-year period, multiple unintended pregnancies, gynecological complaints, injuries, a fall, a burn, a car accident. These are all possible indicators of abuse. We see several negative IPV screens, and it's important to note here that that doesn't necessarily mean that there was no IPV. In fact, we see that there's evidence of IPV. The coordinator notes that the IPV has been going on over a 10-year relationship period. So just because there's a negative IPV screen doesn't mean that there's no IPV going on. Doesn't mean that you should question and interrogate the person, but it does mean that you should keep in mind that there may be reasons why someone is not disclosing. Also important to note here about the former relationship, reference to an ex-boyfriend and the fact that he's incarcerated, and to note that having a relationship be no longer a current relationship, having someone even be incarcerated doesn't preclude ongoing abuse. I also want to note here about the documentation being patient-centered and safety-focused. You'll note here that there was a notation at veterans' request, detailed information is not documented, which suggests that there was a conversation with the patient about what was okay to document or not document in that medical record. Introducing you here to Gloria. I'm not going to go over 4 years of detailed medical records. I just want to share with you that Gloria is a 64-year-old African-American woman who was screened in primary care with that EHIT screening tool. And on that tool, she reports that her partner in the past year has sometimes insulted her, frequently threatened her with harm, but no report of physical or psychological forms of violence. She's referred to the embedded IPV coordinator that this hospital has. And the IPV coordinator note reports documents patient permission for session content to be documented, suggesting that there was that conversation about documentation, which is important. Notes a history of physical assault, in fact, stabbing 2 years prior, for which her partner spent time in jail. So even though she reports no physical violence in the past year, there had been physical violence in the past. She reports that she wants to stay married, loves him, wants him to get help. The IPV coordinator provides empathetic and reflective listening, validation, processing thoughts and feelings, local community resources, and invites future follow-up. About 4 months after that encounter, in the primary care note, there's a note of home stress and that the patient is declining resources right now, but notes that they are available. So some key takeaways to remember here. Remember that IPV is not limited to younger women. So Gloria, as a 64-year-old, would not fall into that reproductive age group, but we see here that she still is experiencing ongoing IPV and can benefit from some support. Note that abuse can be long-term and may change over time. For example, the history of physical violence, but not reporting that in the past year. Seeking safety can take a long time, especially if it is a long-term relationship. And we see here that the IPV coordinator notes that providing validation, empathetic support, follow-up and check-ins resources can be helpful. We might not see a major change right away, but there was documentation that Gloria welcomed and appreciated these resources and interventions. So I want to kind of come to an end before we open up to discussion and questions with a few reminders here that this work that I've shared with you has been focused on the healthcare setting and on experiences of women, because that's where I have done a lot of this research. But I want to be clear that a lot of the lessons learned here really transcend the healthcare setting into other settings and interactions. I also want to be clear to remember that IPV experience is not limited to women. Even though most of this work has focused on women, we know that people of other gender identities also experience IPV. Also want to remember that IPV is not a singular phenomenon, and impacts can be long-lasting. It's not a single event. It's not one form or type of experience, but it can be a wide-ranging experience that changes and is fluid over time. And some key takeaways, some principles to remember. Safety is paramount. Psychological safety, physical safety. We need to consider people's experiences of safety in the context of trauma. We need to be sensitive and trauma-informed. Think about what people's needs might be in the context of this experience where people may feel like they are not empowered, that they've been restricted, that they've been controlled. We really want to help people regain some of that feeling of control. Be client-centered in our work. Note that what works for one individual is not going to necessarily be the same for someone else. When we're talking to someone about IPV, when we're inquiring, we should be doing that in private and alone, not with someone's partner right in a room with them, for example. It's critical that we take a caring and non-judgmental approach, that we don't respond with, why would you let that happen to you? Or you don't look like somebody who would be experiencing this, or why are you with this jerk? Or you should leave right away. Those kinds of things really inhibit future disclosure and help seeking. In our response, we want to be empathetic. We want to provide validation, assess people's safety concerns and needs, not pressuring someone. We had someone talk about feeling like the clinician was bulldozing her and pressuring her, and that really inhibiting future help seeking. These things can take a really long time. People who are experiencing IPV are experts in their own lives, and we need to really support that trust and empowerment in that context of trauma. Want to remember that documentation really needs to be guided by those principles of trauma-informed care, should be guided by client self-determination. We should discuss the limits of that confidentiality and really let that individual have some control over what's going into their documentation and what those responses are. This I want to share with you is a graphic recording of a session that we had with some IPV survivors and clinicians in a pediatric healthcare setting, where we asked survivors to talk to the pediatric clinicians about, what healthcare providers can do to help the survivors who are often here, the caregivers of the pediatric patients, what people need. People talked about a need for safety and reassurance, for understanding, for being given information and transparency. What's the timeline? What's happening next? What are our rights? What are you going to be doing? What are you going to be reporting? And really feeling like the importance of having cooperation and a team effort, that we're in this together. You are here to help me, not to sort of push me in any particular direction. That asking these questions is the beginning, it is not the end point, that this is an issue that affects our whole family. Remember that follow through is so important. People talked about the importance of trust and being there when you say you're going to be there. And that the healthcare setting is a portal and a connection point to other services. It is not the end point. I have a number of references for those who are interested. I can send you any of these. These are the references that I have used in this presentation. I want to acknowledge that much of this work has been funded by VA Health Services Research and Development, by the Robert Wood Johnson Foundation, and not funded by, but a community partner with whom I work closely and who is a leader in this work is the Lutheran Settlement House Bilingual Domestic Violence Program, located in Philadelphia. I will stop there and open up for questions and discussion.
Wow, well, thank you, Melissa. That was really informative. And I really loved how you presented the overall story and really emphasized that it's the lived experiences of these individuals that really should guide the way we respond and support and help develop interventions and evaluation protocols. It was really super helpful. Thank you. So we have a few questions from the participants. One is that sometimes partners may yell or say things that are hurtful or demeaning in the heat of a rare argument. Is it possible that the E-hits or other measures of IPE might have too low of a threshold and pick up these incidents? Or is the definition of IPV much more inclusive than I ever thought?
Thank you so much for that question. I think that's a really excellent point, and want to reiterate that these screening tools are not diagnostic tools, and IPV is not a diagnosis. We are not telling someone, you're experiencing intimate partner violence or domestic violence, but you're not. This is really a tool to help open up a conversation, and that should lead to further inquiry and discussion. So yes, somebody might say, yes, my partner shouts at me or even threatens me. The next step is to then talk to that person about, okay, so what's that like for you? What is the impact of that? And probe a little bit more. Someone might say, yeah, that's how we talk to each other. That's our culture, that's our style, that's our norm. And that's fine. I think we always want to still offer resources and say, sometimes these things can escalate to where people don't feel safe or supportive. And I want to let you know that resources are available. But again, we never want to force anything on someone. So these are tools to help facilitate a conversation and to probe further, but they are not diagnostic tools. At the same time, someone could screen negative on one of these screening tools and yet still feel threatened or uncomfortable in their relationship. And that's something that we can offer and support to people as well. So yes, just because someone says their partner yells at them or calls them names or threatens them or even hits them, that those people may feel completely safe in that relationship, and that's important to validate as well. Oh, Amy, you're muted.
Thank you very much for that. To follow up on that, Lolita asks, Thanks for discussing the EHIT screening tool. Are there other commonly used IPV screening tools that you can discuss or name?
Yep. There are several tools people may have heard of. A tool called the Abuse Assessment Screen, the HARC tool. There are a variety that are similar. There are also cases where people use a 1 or 2 item screener. So people may have come across the question, are you safe at home? We tend to think that's actually a pretty terrible question to use, largely because people don't know what that question really refers to or means. So it could be that I don't feel safe at home because my stairs are rickety, or there's a lot of gun violence in my community. It could also be that I feel perfectly safe at home, but I have someone who's making me feel unsafe in some other context. So it's just not specific enough. There are other screens that ask about sort of seem limited to physical violence. Is anyone hitting you kind of thing? Those are really limited and problematic too. I like the EHITs because it does include these various forms of violence, but none of these is perfect. And in fact, really, sometimes a best case scenario is just looking someone in the eye and really showing care and asking them, how are things going for you? Is there anyone who's making you feel scared or threatened or harmed? We have resources that we can help you with, and engaging someone in that conversation rather than feeling like you need to stick specifically to a screening tool. These tools are used in clinical care. They're sometimes also used in research surveys and other kinds of research assessments where it may be helpful to look at sort of a standardized tool for statistical purposes. But in clinical care, I think it's really important to just prioritize that trauma-informed interaction rather than the specific screening tool.
Oh my gosh, I agree. As a hospitalist for a very long time. And it actually leads us into the next question, which is related to the systems in which providers work that can really impact your ability to slow things down, close the computer, make that eye contact, share a few deep breaths. And that is with increasing pressure on clinicians to see more patients in less time, and the expectation that for payment for services, there's increased detail required for documentation. How do you recommend that clinicians make the time for this type of thoughtful and incredibly important screen?
Yeah,
and care?
It is a challenge, and we know from research that is decades old that has brought up this concern from clinicians about this idea of like opening Pandora's box, right? If I ask this, then am I going to be, stuck with this patient for the next hour and a half when I have a whole line of patients waiting for me and I'm only given, 6 minutes per patient? So it is a systems issue. We do need to push on systems, healthcare systems, insurance systems, screening and counseling for intimate partner violence is part of the Affordable Care Act provision. So there are some provisions for this, but yes, there are systemic and structural issues that get in the way. We do find that concern about opening Pandora's box is rarely an issue. It's really, it's not typical that you ask someone if they're experiencing intimate partner violence and then they say, yes, and as a matter of fact, I'm here with my 3 kids and we have nowhere to go. I mean, if there's that kind of emergency, they might show up with that kind of emergency anyway. If you're conducting routine screening, this is often not something that's going to lead to some kind of big breakdown like that. But what we really do hope, and in the best case, is that you have other resources that you can help connect someone with. So I referred to the embedded in the hospital system, this IPV coordinator, which the VA healthcare system has nationally, a VA IPV assistance program with a full-time IPV coordinator at every VA hospital. Not all healthcare systems have the ability to have those resources. Kaiser Healthcare System has something similar. I also referred to the Lutheran Settlement House located in Philadelphia. They have a program that works within healthcare systems where they embed a IPV advocate within the healthcare system. That's kind of the best case scenario where you as the healthcare clinician can screen and ask and then say, you know, I have a colleague here named Amy, she can help you with this. Can I connect you with her, kind of thing? Or being able to have some other kind of warm handoff within the healthcare system is really the ideal scenario. But what we hear from healthcare clinicians is that in most cases, these interactions, it can be very brief. It can be a couple of minutes where you're turning away from the screen, asking someone the question, telling them, you know, that you thank them for disclosing this, that you understand, that you are sorry this is happening, and that you want to help provide them with care. And I will put in a plug here for this is where social workers can be particularly helpful in the healthcare system. Social workers tend to get paid a lot less than physicians. We should be investing in social workers to provide this kind of support in healthcare settings.
That's great. Thank you for such a thorough response and really giving folks some other ideas. We have some really great questions that sort of all kind of stem from this question. So Barbara asks, what method of communication would you suggest when you are working with somebody if the partner or the parent, I'm thinking if that's a situation for a parent-child, does not wish to allow the client to be examined or interviewed by the PCP or any other provider without their presence during the visit?
Yeah, this is something that comes up, and I want to note here on this slide, one of the resources I've listed is Futures Without Violence, which is a national organization. You can look them up on the internet. On their website, they and others have lots of great, really specific tips for these kinds of situations. So I didn't go into all of the details and nuances about how to do this, but there is lots of information out there. And I also have my email address on here. You can feel free to reach out to me. But yes, when there are times when you can't get someone alone, the recommendations are to not conduct screening with anyone over the age of 2 in the room. So if you're with a 9-year-old child or even a 4-year-old child, it may not be safe to ask that caregiver if they're experiencing some form of harm or violence or abuse. What Children's Hospital in Philadelphia does is they have a laminated sheet with questions. They have it in English and Spanish, and I think are developing in other languages that they will hand to the caregiver if there's children in the room who are over the age of 2 but not with other adults in the room, that says, you know, you may be experiencing any of these variety of things. We have people here who can help you with this. Would you like to talk with someone further? And the clinician says, please read these questions. The only question that I'm asking you to answer is this question at the bottom, this yes, no. Would you like to talk to someone? And all the person has to say is yes or no. Of course, that is limited by literacy. And so it's not perfect. But in a situation where someone is with another adult and that adult refuses to leave, that can be a red flag and an indicator. And so sometimes when people have clinical suspicion, clinicians have gotten really creative to say things like, I'm sorry, but it's hospital policy that we have to do this part of the exam in private, or I need to take the patient down for an ultrasound, kind of thing. And so when there is real concern, clinicians have been known to be very creative and find ways of doing things like that. There are also ways of kind of getting information to people. So also make sure that you just have information available, have information in bathrooms and other places where people might go on their own, have hotline numbers available, have resource sheets that aren't just, you know, domestic violence hotline, but might say, here's where to go for food, and here's where to go for clothing, and here's where to go for employment support, and here's where to go for domestic violence or family stress. So if you're giving someone a resource sheet, you may be giving them that information, but really not highlighting that. So people find really creative ways to do that.
And it's great to hear that there are some systems in place. I remember learning that the airline industry actually even has systems in place for when They have concerns about passengers on a flight and how they can reach out and respond to the passengers if they believe that the passenger is experiencing domestic violence, and how they can offer support and resources. So these are systems that cross outside of the realm of healthcare as well.
Absolutely. So we can think also about school systems, hair salons and other kinds of places like that, dental practices. It's really ideal if everybody can be informed. And again, especially during this pandemic, it may be more important to have, friends and family and neighbors kind of be informed. So, to help others to sort of know what some of those resources are and where you can reach out for help and where you can help someone else reach out for help can be really important.
Absolutely. So you mentioned a few things about recognizing that across cultures, the concept of what it means to be safe, and also how you define or construct your relationships, and what principles feel safe or unsafe are very different across cultures. So somebody asked, do you feel cross-cultural competency or awareness needs to go hand in hand with trauma-informed training related to IPV to prevent damaging stereotypes overshadowing support being offered?
Yeah, I think we should always be cognizant of culture, of social factors, of individual contexts, and at the same time being really careful about sort of not holding cultural or social stereotypes or making assumptions. I think it's really important to engage with people about what feels right to them in their experience. And although we talk about intimate partner violence in terms of a particular experience or behavior, has someone hit you kind of thing, what we really want to probe into is like, what is the impact, right? Do you feel controlled by this person? Do you feel afraid of this person? Are you experiencing kind of those trauma effects? Because it may be that for you, this is not a problem, whether that's due to your culture or anything else. So it's really about engaging in a conversation. We should always approach people with cultural humility, always realize that there are various contexts going on, always realize that people may face a lot of barriers to disclosing or help seeking because of all of the different parts of people's lives, as well as about their interactions with you. So those are always important pieces, yes, to keep in mind.
Thank you so much. And when you talk about that it can impact and cross over in a variety of areas of life, I was sitting here thinking, as a pediatric provider and researcher, boy, how do we think about children? And then Crystal chimed in saying, are there tools that you're aware of that help explore if children are exposed to IPV? And I would layer with that, beyond screening tools, are there specific behaviors or characteristics that providers for children should be aware of in schools and healthcare that they might be being exposed to IPV?
Yeah, so we do know that IPV exposure can impact children. Exposure to IPV is considered one of those adverse childhood experiences categories. We also know that, IPV exposure in and of itself, although it can be harmful for children, it does not necessarily meet the threshold or definition of child abuse or neglect or maltreatment. These conditions often overlap, but this is something that comes up a lot in the pediatric setting, because the pediatric setting is a place where people can get help and support for experience of intimate partner violence. And often getting that caregiver help and support really is what is helpful to the child. But if parents or caregivers feel like, if I tell you that I'm experiencing domestic violence, you're calling Child Protective Services and taking my kids away, that's really going to inhibit that help seeking. And ultimately, that doesn't serve the child well. So children can experience trauma from being exposed to intimate partner violence. And that, as we know, can manifest in various ways. in children's experiences. And so intimate partner violence programs, domestic violence programs often do also provide counseling and therapy for children as well who have been exposed to intimate partner violence.
And are there specific characteristics? So let's say you're a school teacher or some other provider in a school, and so you don't really see the caregivers, the home caregivers, all that often. Would there be behaviors that providers should be looking for?
Right. So, yeah, if kids are displaying sort of symptoms of a trauma response, or maybe they're feeling like they're not getting enough sleep, or they're very anxious, or they're very worried, those are the kinds of things we might probe into. Is something going on at home? Is something making you feel worried or upset? Often that is where we get disclosures of intimate partner violence. It is why Children's Hospital of Philadelphia and other children's hospitals across the country have domestic violence programs and relationships with domestic violence programs. So we can ask children about what's going on. I wouldn't say that there's a particular kind of symptom set that comes up among children who are exposed to intimate partner violence. It is just such a varied experience. And we may have an image of, parents sort of fighting and shouting and slamming doors and bruises and broken bones and things like that. But often it doesn't look like that, but children will still pick up on the fear and the anxiety. And so engaging children in conversations about the extent to which things feel safe or worrisome at home, and then getting them some support and connecting in with a domestic violence program can be immensely helpful for that too.
Well, I really appreciate that, because it really aligns with, from a trauma perspective, that behavior is an expression of need, and behavior is not stereotypical to any one particular situation. So, for a while, there was a pretty generalized stereotype that if a child was acting aggressively, then we could presume that they were acting aggressively because they were living within a situation where there was some sort of violence or domestic violence or intimate partner violence happening. And what I hear you saying is no, right? Really, we just need to be looking at behaviors that children do that might indicate that they are experiencing some stress, whether it's fight, flight, freeze, or fluctuating behaviors.
Right. And sometimes that looks like parentification, right, among children who, and this can be in any kind of adverse situation, right? We see this when there's problems with unhealthy substance use among parents or caregivers, right, where a particular child might step up to be overly responsible in that situation. Trauma responses really do look different among everybody. I think, asking the question, validating and providing support and safety and connection to resources can be really helpful. And yeah, I think that it's a really good point, Amy, about sort of not making assumptions or judgments or stereotypes.
Yeah, great. Thank you. And one more question linked to the children or pediatric piece. So Dr. Kapulski asks, could Dr. Dichter please comment on how healthcare providers navigate screening in pediatric contexts, given the possible overlap with Child Protective Services? I'm thinking especially about how tricky this could be in jurisdictions with mandated reporting, where IPV is legally defined as child maltreatment, and or the non-offending caregiver may not be exonerated from substantiation in a maltreatment case. So it really does complicate things.
It is really tricky. Pediatric providers are hopefully well informed about mandated reporting and about how to talk with caregivers about the mandated reporting. In most cases, exposure to intimate partner violence does not constitute child abuse or neglect per se. There have been legal cases ruling that. But we do know that can be a risk for kids. And it is a really tricky situation when, for example, mom's boyfriend is the perpetrator of violence or abuse, for example, but doesn't have a legal relationship to the child. In that case, Child Protective Services doesn't have jurisdiction over boyfriend. They only have jurisdiction sort of over mom. So that's a time where the pediatric provider clinician can engage with that caregiver and talk with them about how do we get services and support to keep you and your child safe. And it's really about working together in that situation. Every parent who's experienced domestic violence who I've talked to is primarily concerned about their children. It is their concern for their children that motivates their help seeking. People say, I just tolerated it until my child was born, or I saw that my child was affected, or I worried about my child. People are generally motivated to get the best care for their children. And so it needs to be a collaborative effort. Historically, there's been a lot of tension between the sort of intimate partner violence and child welfare fields. And I think we're doing a lot of work to try to pull that apart. Like I mentioned, Children's Hospital of Philadelphia has a relationship with the domestic violence program. The City of Philadelphia Office of Domestic Violence Strategies spent their first year in operations embedded within the city's child welfare system, the Department of Human Services. We have gotten better about integrating those services, but we need to pull in the domestic violence experts with the child maltreatment experts and recognize that this is a systemic issue and that the best way to support the kids is to support their caregivers.
So sort of growing on this, but expanding beyond children and expanding beyond immediate intimate partner. Somebody has asked, are there screening tools available that are more general and which encompass other types of violence from different types of family members? So it may not be intimate, but it may be an uncle or a grandparent.
Yeah, absolutely. I think it is one of our challenges that we have sort of segmented these different forms of violence and abuse. And if we're asking about a current or former intimate partner, but we're not asking about other family relationships, we may be missing something. Our screening tools, they haven't been great about that, because what we find is when you get too broad, you get the kind of, are you safe at home question that just isn't specific enough. When we, asking about, are you being abused by anyone, doesn't tend to be a good question, because people, may not think of their experience as abuse, may think that you're asking about physical violence. So I would say that if it's part of a clinical encounter, that you're doing that additional probing, you're talking about, where we can provide you help, and we're worried about any experiences of anyone making you feel threatened or harmed. And so in a clinical encounter, hopefully you can have that more open discussion. But it is true that most of the screening, the sort of structured screening questions themselves are pretty specific.
Thank you, Melissa, for answering that. Tawanda is asking if it would be possible to get a list of the screening tools. Do some of these resources that you have indicated here have specific screening tools? I know you said Futures Without Violence has a lot of tips. Is there one of these that could offer access to the different screening tools you've mentioned?
Yep, the Centers for Disease Control and Prevention has a compendium of screening tools. Futures Without Violence does. HRSA has screening tools on their website. AHRQ, I know I'm throwing out a lot of acronyms and I don't want to miss what they're actually stand for. But yes, there are a variety of screening tools that can be found on these different resources.
Okay.
And people can also feel free to directly email me afterwards if you're having help or wanting help sort of finding some of those.
So this is a really rich conversation And I'm so glad that you left time for all these questions because these are really wonderful questions. And this is clearly a topic that is one that a lot of people have interest in, and great questions. So another person has asked, other than obvious evidence of potential IPV, so physical trauma seen, is there a list of high-risk patient populations that clinicians could begin to target? For example, couples who are divorcing, lower socioeconomic patient populations, ethnic disparate populations. What does the research say about high-risk groups?
Yeah, so we do see that women of reproductive age tend to have the highest rates of recent intimate partner violence. We don't tend to see a lot of other kind of demographic associations. We know that stress can exacerbate tension, and that stress can come from things like economic strain and other forms of traumas and racism and other kinds of experience. So there can be some interaction there. It is also true that when there are things like economic strain, it can make it more complicated to escape a situation in which there is violence. But I think we want to also be really careful that we know that anyone can experience intimate partner violence. And sometimes our statistics are a little bit skewed. So if you're looking, for example, of who are the characteristics of the people who are going to domestic violence shelters, that's going to be skewed because the people who have other resources to, get their own apartment or stay in a hotel or fly across the country to stay with a family member, they're not showing up at those shelters. So the data there are really skewed. Anytime there's increased stress, certainly if there's separations and divorce and things like that happening, those can increase risks of violence. When there's substance use does not cause intimate partner violence, but there can be an interaction there. So those kinds of things can increase risks. But demographically, we really see that this is a situation that affects all segments of the population. And we should make sure that if we're not doing routine screening for everyone, we're certainly making resources available to everyone.
Absolutely. Yeah. And that really leads right into Lolita asked a little while ago. So Lolita, thank you for your patience. She's talking about the pandemic and talk about increased stress. She's saying there was an increase in IPV in New York State in early 2020 due to the pandemic lockdown. Has this trend been found and or studied across the country?
Yes, we see increase in IPV all over the country. And in fact, reports from all over the world internationally, we have seen increased due to lockdown associated with the stress of economic effects and other effects of the pandemic, being kind of locked in a home or an apartment or in a situation with someone who is using violence or abuse, fewer opportunities to just get away. So yes, we have seen increases in domestic violence across the country, across the world. And that earlier slide, I grabbed just some screenshots of headlines, but if you Google COVID-19 and domestic violence, you'll find many articles about this that report on anecdotal reports as well as emerging research in this area.
That's great. Thank you. This has been really wonderful. Brandon posted that they really appreciated the reminder to explain what actions will be taken with the information that's collected. And I'm sure that they are just one of many people here thinking about all the really amazing information that you have provided that they will be able to take home with them and really think about and apply it to whichever field or school or wherever they are at the moment. So thank you so much. Stephanie says, great information, inclusion of the information tools and training. Thank you. Any other questions for Dr. Dichter? Okay, thank you all so much for being interested in this topic, committed to your learning, that you're joining us on a Friday afternoon, 1+ year into a pandemic. And we really appreciate you all and hope to see you at the next seminar. Dr. Dichter, we are so grateful. Thank you.
Thank you. Thanks, everyone. Take care.